Good morning. My name is DeWolfe Miller. I'm a professor of epidemiology at the John A. Burns School of Medicine in the University of Hawaii, Honolulu. I am very happy to be invited to this scientific meeting at Ahmed Maher Hospital. I'm pleased and honored, and I'm thanking all the participants who are attending. I hope that my presentation on hepatitis C and the epidemiology of hepatitis C in Egypt will be a useful contribution to the conference. And I have to tell you that this is my first time doing a video presentation in such a manner, and so I beg your patience. I hope that this goes well. First, I want to just give you a quick outline of what this presentation, I'll try to include in this presentation, which is a brief overview of the virus, how the discovery of hepatitis C in Egypt occurred, some general information about the epidemiology and transmission of hepatitis C and the unique transmission of hepatitis C in Egypt, which leads to the discussion of iatrogenic transmission and infection control. That will be followed by a review of the national population studies of hepatitis C that have been completed in Egypt at this time and their interpretation, which will introduce us to the notion of hepatitis C incidence, or the new cases of hepatitis C that are being caused by iatrogenic transmission, and introduce the idea of evaluation of prevention measures and the concept of the epidemiology of hepatitis C exposure. And I'll complete the presentation with a brief notes on the epidemiology of eradication. So this is the next slide. This virus is very small. It was identified only recently in 1990, 1998, and it was identified immunologically. It's never been cultivated in vitro. It's found only in humans. It's very fragile outside the human host. It's a very slow-growing virus in its host. It has low pathogenicity, 33% recover with antibody, and that means that we have a large population of asymptomatic people with HCV RNA viremia. However, those who do demonstrate clinical symptoms have serious liver pathology, so it has high virulence. This virus does not confer immunity, and a person that is cured of hepatitis C can be infected again. There's a very high mutation rate by this virus, which means that it's going to be difficult to develop a vaccine for it. And the infectivity of this virus, interesting, is actually very low, close to what we see for HIV. More on that later. Okay, so hepatitis C virus is a classic human bloodborne pathogen. There is no other known host or reservoir other than humans. It's transmitted by the exposure to blood from another human who's infected and viremic. A common transmission is among injection drug users who are sharing unclean injection equipment between the drug users. Transmission by other bodily fluids other than blood has been documented, but these are rare and epidemiologically not really significant. Hepatitis C is preventable. In fact, it's 100% preventable. Globally, the hepatitis C prevalence is low, mostly because of intentional or unintentional prevention measures. For example, aseptic procedures in healthcare, which have been instigated and started and practiced around the world for a long time. Nevertheless, iatrogenic transmission also occurs. It occurs throughout the world, but usually at very low levels. The epidemiology of hepatitis C is to start with, it is a global public health problem with 130 to 150 million people chronically infected all over the world. The average prevalence in any particular country is between 1% and 3%. In Egypt, where the prevalence is much higher, This is really a unique situation that we see in the world today. It's such a high prevalence in the country and in Egypt. Hepatitis C related liver disease around the world creates about 500,000 deaths a year and is responsible for almost 30% of the cirrhosis and 25% of the hepatocellular carcinoma. This is a leading cause of liver transplantation. The discovery of hepatitis C in Egypt is interesting and important. Second-generation ELISA assays for hepatitis C became available in Egypt in 1992. Before that time, the status of hepatitis C in Egypt was completely unknown. This was true for most of the countries around the world at that time. Other European countries who had received these second-generation ELISA kits before Egypt were reporting 1 to 2% of those that they had tested positive for hepatitis C antibody. So the first report in Egypt was by Dr. Momina Kamel and her team, who tested 2,164 first-time healthy blood donors in Cairo using the second-generation doubly positive ELISA test. 10.9% of hepatitis C antibodies were found positive in these first-time healthy blood donors. This was quite shocking. This was not expected. The entire test of all the specimens was done again just to assure that it was really true. It was 5 to 10 times higher than the prevalence that had been reported in any other country in the world. This was published rapidly in Lancet, and I was one of the co-authors. I helped with establishing the study and analyzing the data. The second follow-up after the discovery in the healthy blood donors in Cairo, a rural population-based community study was organized and supported by Dr. Kamel. This included the entire population of this small rural village in the northern Nile Delta. The results from that survey, which actually included many other indicators such as schistosomiasis, ultrasonography of the liver, hepatitis A, hepatitis B, and hepatitis C, but the overall prevalence of hepatitis C in the village was 17.6%. The interpretation is that high prevalence of hepatitis C was very likely be high throughout Egypt. And this was already strong evidence now of a hepatitis C epidemic. And public health intervention was clearly justified. And this was also published. So one of the important discoveries in both the blood and the village data was that that prevalence is strongly increases with age, as you can see on the graph at your right. And the prevalence is, although it's similar, it's different in the sexes, but it's very closely similar. But in this top curve, this is the curve that was fitted with a logistic regression of age-specific prevalence of hepatitis C antibody in the village, and the lower one is from the Cairo first-time blood donors. Dr. Kamel also supported a case control study with two population-based control groups on the hypothesis that hepatitis C was associated with primary pathologically defined hepatocellular carcinoma. New cases were recruited and classified by primary pathological findings from Kasserlani Hospital. The findings of this study was a strong association, odds ratio greater than 5, between hepatocellular carcinoma and hepatitis C infection. This was the first ever reported epidemiologic association of hepatitis C and hepatocellular carcinoma. The contributions of Dr. Momina Kamel really need to be recognized. Her efforts of research and publication led directly to the mandated screening of all blood donation in Egypt for hepatitis C. This was an enormous accomplishment to which I'm a witness. I feel compelled to remind all of this great contribution and great effort on her part. And I'm lucky, thanks to her, to have played some small role in collaboration with her during this exciting public health discovery. At this point, in 1994, there was a sufficient amount of epidemiologic data because there were certainly numerous other studies appearing from rural communities and clinics, all finding high prevalence of hepatitis C. So there was certainly enough information and evidence to assume a national epidemic, understand how hepatitis C was transmitted, focus on identifying iatrogenic exposures, which we had all been personal witness to, planning a national public health prevention campaign to reduce iatrogen exposure and prevent the transmission. This is what would naturally follow. But it didn't happen. What happened is that because of the large asymptomatic group, this became essentially a silent epidemic. And by 2000, a report published in Lancet attributed the hepatitis C epidemic to the historic widespread rural campaigns to control schistosomiasis by treatment with parenteral antischistosomal therapy. There's no doubt that these campaigns were widespread, that they were using glass syringes and needles, and that the glass syringes and needles were probably, many of them were not properly cleaned and sterilized. However, this study, published in Lancet, was ill-conceived and flawed. It's an ecologic study for which you can only, even if it was well done, have limited interpretation, was embraced by the world and Egyptian healthcare system as an explanation for the hepatitis C epidemic. And that PAT, or parenteral antischistosomal therapy, was history. Therefore, the epidemic and the transmission ended years ago. This was how the healthcare system around the world interpreted this paper. And since these campaigns had finished, there was no more transmission occurring. So it was bad that it happened, but we can now relax because of this publication, which many of us were really disturbed by because we knew that this wasn't the case. Clinicians all over the world attribute hepatitis C epidemic in Egypt to this campaign. And the same way that the Aswan High Dam is attributed to causing an epidemic in schistosomiasis in the first place. Both are false. The PAT campaigns were an obvious index, which are readily recognized, of a much greater, and it masks the concurrent iatrogenic exposures that were occurring throughout the entire Egyptian healthcare system at the same time. Much larger. The epidemiology of hepatitis C globally and in Egypt is actually well established. The virus is inherently labile, much less infectious than hepatitis B, and slightly more infectious than HIV. The probability of HCV transmission, however, will vary by the routes of exposure and is summarized in the next table. Okay, this table was published by myself and colleagues in Egypt and elsewhere to get an overall picture of hepatitis C transmission in Egypt. For example, blood transfusion has a 100% transmission probability. If you receive a blood transfusion that's contaminated with hepatitis C, you will be infected. And that's 100%. And the same is true for organ donation. However, since now in Egypt and since the 1994 and after, the mandation, the fact that the blood transfusion in Egypt is screened for hepatitis C is mandated. There's probably it's not completely 100%. There's always problems with all blood transfusions around the world, but in large part, it has been successful in preventing thousands, tens of thousands, or even hundreds of thousands of people since that time from becoming infected. Injection drug users is well documented that transmission is high. However, the role of infection drug users in a community epidemic would be limited. And the same is true for of hemodialysis. And then there is the issue of sexual and intrafamilial transmission, which I'll go back to later. The big part of transmission in Egypt is due to iatrogenic transmission, the one here on the bottom, which is high. The transmission probability is low, but because of the large population that is exposed, its significance is the highest. There is, at one point, there had been studies in Egypt that were published on intrafamilial transmission. The validity of these studies are hard to establish due to small numbers, the issues of confounding and selection biases. They haven't been replicated. There's no specific intrafamilial exposure to hepatitis C that's been identified. There's been plenty that have been suggested, but not, there's no solid epidemiologic evidence indicating as such. Sexual transmission, of course, is also unlikely to play any significant role in Egypt, even though it also is controversial. Nevertheless, these studies have been cited as a major hepatitis C route of transmission again deflecting attention from the role of healthcare in iatrogenic transmission. I just want to add here that I think all of you should make it clear to all your patients and any of the people who have any influence in the healthcare system and in the political system that there is no justification for divorce or job termination. I learned this by working in Egypt, by knowing that the World Health Organization doesn't justify it, that our CDC in the U.S. doesn't justify it, and from Dr. Gamel Esmet, who would like to see the lack of stigma. We want to see the reduction of stigma from hepatitis C. This is very important. Hemodialysis patients, of course, have in Egypt it became a real problem, and it was widely publicized in the media as well as in publications. The issue of controlling hepatitis C in hemodialysis units or in other clinical settings such as thalassemia clinics where it's difficult to have prevention or preventing iatrogenic infection is through a simple process of cohorting, or you screen patients beforehand and then assign patients who are negative for hepatitis C to negative facilities with dedicated equipment, and those who are positive for hepatitis C to the facilities who have only hepatitis C positive patients. This has been used around the world in other places because there's been plenty of other countries that have had problems with hemodialysis control of hepatitis C in hemodialysis. However, the general population, is not really exposed to this hemodialysis, and so it really plays a small part in the overall Egyptian epidemic. We did a study, our group did a study on modeling the vertical transmission. It's well documented that children born to mothers who are hepatitis C antigenemic or have viremia to hepatitis C viral viremia, that they become infected. It's just that this is not a transplacental infection. Mother-to-child infection is occurring through some unknown mechanism, but it's clear that mothers who are infected and are viremic do transmit it. The rate at which they transmit it, however, is what we have modeled and got, I think, some very good estimates for. And so we estimated between 0.03, the probability of 0.035 to 0.058, or 3.5% or 5.8% of hepatitis C vertical transmission, and estimate that 5% of the total national hepatitis C incidence is due to vertical transmission. Needle sticks, of course, are a big occupational risk in healthcare, and this is through needle stick studies do we have good ideas about the probability of transmission of hepatitis C, where we have a person in healthcare who we know to be negative, who has an exposure to a needle stick from a patient who is confirmed to have hepatitis C RNA viremia, and we find that the probability of transmission is fairly low. okay, and just slightly greater than HIV. This is really good news in that infection control and the control of bloodborne pathogens in the healthcare setting should be very, very effective. Unfortunately, accidental needle sticks are a common exposure, and we should take every opportunity to reduce that exposure by good practice. Iatrogenic transmission of hepatitis C has been documented all over the world. It can be complex due to the many routes of exposure, from contaminated medical and dental instruments, sharps, needles, invasive procedures, contaminated multi-dose vials, blood or blood products, transfusion, organ transplantation, and many kinds of medical and dental percutaneous exposures. The key element of iatrogenic transmission is patient-to-patient exposure, where the first patient, knowingly or most likely unknowingly asymptomatic infected, contaminates some medical instrument, sharp or needle, which is then used on the next patient without adequate disinfection, therefore transmitting the infection to another person. So this is actually a healthcare setting transmission that's occurring, and that's why we call it iatrogenic. Many reports identify iatrogenic transmission as the principal driver of hepatitis C in Egypt. And iatrogenic transmission can be prevented. I can't repeat that enough. Accordingly, in Egypt, if the probability of iatrogenic exposure is the same across the healthcare system, then the probability of transmission will be greater in patient populations who have a higher prevalence of hepatitis C RNA infections, symptomatic or not. What you can be assured of is that because of the strong association with age, your patient population, the older patient population, is going to have a higher prevalence of hepatitis C RNA positivity than the younger patients. And therefore, you should be taking more care and more infection control in those settings. This varies in rural populations where the hepatitis C positivity is higher relative to urban populations. So, I want to bring you to the review of the national population studies of hepatitis C in Egypt. There have been 3. The first one was in 1996. The report of this national population study was published by M.K. Mohammed. This study, I will, as with the other 3 studies, the other 2 studies, I'll review completely. The other 2 studies, the one in 2008 was also a national study, and both of the next 2 studies in 2008 and 2015 were conducted by Dr. Fahma El-Zanati, who is a professor of biostatistics at Cairo University. The first was part of her regular Egyptian Demographic Health Service, who she has been really the main person conducting the Demographic Health Service, which are based on the total national population. The 1996 study, the sample size was 7,357. This was countrywide. And the prevalence was estimated after being adjusted was 13.5%. And the urban antibody positivity was lower, 9.1%, compared to the rural antibody, which was estimated at 18.9%, not a lot different from our first rural village. The study was consistent with other reports in that higher prevalence occurred in rural areas compared to urban, and that HCV prevalence increases with age to age groups 55 and 60. There are some issues and problems and limitations with the interpretation of this study due to the lack of detail in methods, including sampling and the laboratory methods. There were sampling design issues and data analysis problems. The reliability of this study is not as firm as the next 2 studies. In 2008, Fahma Zanati and her colleagues published a landmark study. This had a standardized representative national sample, very large, national sample of over 11,000 people. It included the age groups, and this is important to note, the age groups from 15 to 59. It didn't include individuals younger than 15 or persons that were over 60 and older. It did use standardized laboratory methods for hepatitis C antibody and hepatitis C RNA testing. The overall hepatitis C antibody prevalence was 14.7%, and the overall RNA positivity was 9.7%. There was a strong increase of antibody and RNA with age in men, women, urban, and rural subgroups. This graph shows the very, very clear relationship of prevalence of antibody, which is the top blue squares, and the line that's been fitted by a logistic regression. Using the logistic regression, you can actually estimate the prevalence into younger age groups very accurately. The red triangles underneath are the age-specific prevalence of hepatitis C RNA positivity, which mimics or mirrors the antibody positivity. The results of this study no doubt improved all efforts in Egypt to increase prevention of hepatitis C. The age-specific distribution of hepatitis C was very similar to early studies. The magnitude of viremia in the population was very large. The results and data from this study provide new insights in studies, including the estimates of hepatitis C incidence. This is really key. And that the evidence did not support general public awareness campaigns as an important prevention measure. This was published in PLOS ONE, that when we looked at the evidence of general public awareness campaigns, it really had no impact on prevention. What was important was to have prevention within the healthcare system, which the public has really no control. So just recently, this last year, an even larger study that it included, and this was conducted by Fahmy El-Zani's group again, and it's called the Egyptian Health Study. It's not a demographic health study. It included the younger age groups, including 1 to 59 years old. It included the same ELISA tests and tests for HCV RNA. Now, to compare the two studies is a little bit tricky and is a little bit more complex and not completely straightforward. For example, in this study, the age groups 15 to 59 were 10%, which is lower than 14.7%. And the RNA positivity is in the 15 to 59 is 7%, which is down from 9.1. But you have to remember that the population since 2008 has grown significantly. And that has to be taken into consideration in analyzing this data. A strong increase of antibody and RNA with age was also seen in men, women, and urban and rural populations, except that the rural populations and the urban populations, the difference is a little bit less than in 2008. These studies actually contribute a great deal to our understanding of the epidemiology and have been a terrific benefit to the recognition and control of this epidemic. And I want to salute all those who have worked so hard on these national studies. In 2015, the study also included measures of hepatitis B, which is hepatitis B core antibody and hepatitis B surface antigen, or hepatitis B antigenemia. And it's interesting to note that the antibody, hepatitis B antibody, was 15.7%, and the antigenemia was 2% or less, which is basically good news. And it's a good time to remind all of us here today to get immunized for hepatitis B if you haven't been already. Epidemiologically, this is the first time that we have in the history, anywhere in the world, to study the epidemiology of hepatitis B in an endemic hepatitis C population. These are studies that are underway. So, the relationship between the total hepatitis C antibody and total hepatitis C RNA, which is about 33%, will recover and become antibody positive. The remainder become RNA viremic, has been stable between all three studies, for age, sex, location, urban and rural, and time. There is evidence of changes or differences in the prevalence of hepatitis C antibody and the prevalence of HCVR between these three studies, as you can clearly see. However, the direct comparison of these three studies is complicated and complex because of somewhat in the way in which the methods have been done, the populations have been sampled due to population increases, and other factors. And this is work in progress and that a number of groups are doing to be able to interpret the overall impact of these three studies. There is definitely possible evidence of a decline in hepatitis C incidence. But how much and why is it declining? These are still questions that are to be answered. So what is hepatitis C incidence? Hepatitis C incidence is a new case of hepatitis C, a person who was negative who becomes now defined as positive, whether by antibody or hepatitis C RNA. This is very true in Egypt. To do a hepatitis C incidence study, this is going to require a large population. Okay, I just want to tell you epidemiologically the investigation of the incidence is, I'm just going to tell you what is required here, and it requires large population of people who are all tested for hepatitis C, and then you remove the people who are positive and keep only the people who are negative and follow them up for 1 or more years, okay? And you have to have a large population to do this because at best you're looking at maybe 4 new cases per 1,000 persons, okay? So during the follow-up, you have a difficult time to even keep people in the study over a period of time so that you can come back to them and test them again. And what's even more difficult is how do you know if they've been exposed during this follow-up period? You can't just interview them and expect to get accurate information. This is very, very difficult to establish exposure. Oh, and by the way, it costs lots of money to do these kinds of studies where chronic disease or infectious diseases, these prospective, large prospective, are always expensive. But very important here that I want to make this point, that these studies, because of the complexity and costs, are essentially useless for evaluation of hepatitis C prevention efforts and not recommended. I can testify to this for many different kinds of public health interventions. And most public health interventions will not use incidence studies because of complexity and because they actually don't help in doing the evaluation that's necessary, which is to reduce exposure. What you have to do is evaluate the prevention efforts based on reducing exposure. It's much more cost effective. It's epidemiologically perfectly acceptable. We're not trying to establish causation and can be directly demonstrated. Okay. So, just as a quick summary of what the incidence has been found from the few studies that have been done in Egypt and from what we can also get incidence estimates from mathematical epidemiologic models. So the first study in 2005 that was published on this was a population in the Nile Delta in which the incidence was estimated at 6.8 per thousand. At 2005, this was shocking because it was absolutely unequivocal evidence of ongoing transmission in Egypt when it had been thought that transmission had ended because the PET campaigns had ended. So this was very, very strong evidence that this is not the case. And then another study modeled between 2 and 25.5 cases per 1,000 years in a village in the Nile Delta. And then our model modeled 6 per 1,000. It was estimated from the 2008 demographic health data. The purpose of that model, I need to emphasize this, was not so much to actually get an absolute ironclad estimate of hepatitis C incidence as it was to provide data and evidence for justification to increase resources for hepatitis C prevention. A prospective study that was published on rural women in the Nile Delta, 5.2 per 1,000, and another study that modeled R0, or R0, which is the intrinsic reproductive rate 3.45 means is that for every patient that is infectious, they'll infect 3.5 other people. A cohort of children less than 5-year-olds, the incidence was 3.8 in those in the first year of life and 2.0 per thousand in the 1 to 5-year-old groups. There's plenty of evidence then to show that transmission is occurring in Egypt, and the degree to which it's occurring is certainly serious. Whatever these estimates finally are, it should be taken seriously and certainly sufficient to take measures of prevention. But we actually developed this graph, which we show the relationship between prevalence and incidence, and you can use this model to approximate incidence given the prevalence in a particular area of a rural area or an urban area. Regardless of the exact estimate, hepatitis C transmission is ongoing in Egypt and should be prevented. Prevention. Improving infection controls. This was the first thing that was clearly needed and was published about that this was clearly needed about a decade ago, that there was really serious problems in infection control. And since that time, infection control measures have improved in Egypt. It's not really technically complicated to prevent hepatitis C, a bloodborne pathogen. It doesn't really require any special new facilities or equipment. It doesn't require any pre-screening protocols, and such pre-screening protocols can be established. The hepatitis C prevention in general does not even impact on resources. It's relatively inexpensive. Standard procedures for preventing infection in patients and healthcare workers is a necessity of good healthcare practice regardless. It's something you would need and want anyway. One of the issues of hepatitis C prevention and improved infection control that has come to my attention over time after living and working in Egypt is that who is it that really takes the responsibility for infection control or prevention measures? And my answer is that it should be everybody, and including the patients. The patients should talk to their caregivers and say, you know, we are aware that there is this problem, and we are concerned, and we don't want to be infected. And that should be part of any conversation with a healthcare provider and their patients. It's my impression that this isn't the case, as there are many hierarchical structures in all institutions, including healthcare institutions, and this is something that has to be overcome. So, I'm just going to remind you, have you had your hepatitis B immunization? This is just to show good faith in prevention efforts, and I know that I'm beginning to sound like your mother reminding you to brush your teeth, but I think prevention can have such a huge impact in Egypt that everybody should be promoting it at all times. There have been considerable improvements, and how do we know that these improvements are actually working? To help answer this question, we recently published a paper entitled Epidemiology of Hepatitis C Virus Exposure in Egypt, Opportunities for Prevention and Evaluation. Here I'm going to introduce this concept of the epidemiology of hepatitis C exposure. And how does that work? Well, this is the patterns and determinants of potential exposures in the healthcare system. For example, in this table, you can see here in 2003, hand hygiene was estimated in 48 facilities to be 13.3, and then after the implementation of the improvement of the intervention, it went from 13 to 58. Okay, so these are indicators of infection control: hand hygiene, personal protective equipment, appropriate reprocessing of instruments and sterilization, availability of adequate waste, and an overall infection control score, which increased from 19 to 69, which is a significant increase. Okay? Now, these are just examples of these indicators. They would be different if you were in a dental clinic. For example, in a dental clinic, you might want to know how many instrument sets were given for a particular workload and how their disinfection and sterilization procedures were being done. Two important concepts are implied. That reducing exposure does reduce transmission of hepatitis C incidence. It's implied. Moreover, this concept has been established epidemiologically, and causation has been established and is not in question. Direct demonstration of decreasing hepatitis C incidence is just not required. It's important, however, that exposure assessment and measurement is carried out independently. All of these control programs should be independently assessed. Healthcare education has come to our attention in our group that formal healthcare curriculum needs strengthening in regards to understanding and preventing iatrogenic exposures. And I've noted down here at the bottom here something that says KAP data would be useful. KAP stands for Knowledge, Attitudes, and Practices. This would be a very, very useful tool at the healthcare professionals level. In other words, the provider's level, the individualist practicing, a nurse, a doctor, a dental assistant, the dentist. What is their knowledge of prevention for hepatitis C? What is their attitudes toward it? What do they actually practice? These kinds of studies will be extremely useful in guiding prevention for hepatitis C in Egypt, and I definitely support them. Just a quick note about eradication, and in epidemiology, this is a very specific term. The classic example is the eradication of smallpox, which was eradicated from Egypt and the rest of the world in 1979 by vaccination. Polio has also been eradicated by vaccination, but it's interesting to note that guinea worm or dracunculiasis transmission has been almost all but prevented just by improving water supplies. Mass chemotherapy programs in Egypt that reduce schistosomiasis to near extinction. You can hardly find either Mansenii or hematobium infections in rural Egypt anymore. So here's an example of where you're actually treating people to prevent the disease. And of course, the advent of a single dose of praziquantel used in mass chemotherapy programs really was effective. Hepatitis C, in the hepatitis C Egyptian context, eradication of hepatitis C, to me at least, means reduction of morbidity and mortality, and to the point of being a non-public health issue. I just wish I could have been there personally to give this presentation. I really regret that, and I want to thank you so much for this opportunity to participate. Thank you, all of you at Ahmed Maher Teaching Hospital. I think the world of all of you, and I wish you the best possible future success. Thank you again.